Hi, I'm Maribel Freund, and I'm going to be presenting the antimuscarinic drug class and glycopyrrolate for Nursing 830 Pharmacotherapeutics for Advanced Nursing Roles 2. Antimuscarinics, also referred to by other pharmacologic terms such as anticholinergics, muscarinic antagonists, and parasympatholytics, are all chemical compounds that have been derived from the alkaloids of the belladonna plant species. These alkaloids are found in the leaves, berries, and roots of the plant and have toxic properties, which has appropriately coined its nickname as the deadly nightshade. Back in the day, they were historically used to coat the tips of arrows and to make oral poisons, and is thought to be the infamous concoction that Juliet drank in the Shakespearean play Romeo and Juliet. Cosmetically, they found use as pupillary dilators, and back in the day, larger appearing pupils was seen to be an attractive trait. Medicinally, they found some use as surgical antiseptics, and then later on in modern medicine, they are currently used to treat and manage a number of symptoms and conditions. In anesthesia, they are used throughout the various phases of perioperative period and used for various reasons. These agents come with a variety of effects and therapeutic benefits. Antimuscarinics are competitive antagonists of the neurotransmitter acetylcholine at muscarinic cholinergic receptors. These muscarinic receptors are part of the parasympathetic division, and normally activation of these receptors elicits the rest and digest response. These agents work on muscarinic receptor types 1 through 4, which are centrally found in various regions of the brain and spinal cord, and peripherally on the heart, smooth muscle, and exocrine glands. They are also found on sweat glands, which are actually innervated by the sympathetic division. These agents compete for receptor binding sites with acetylcholine, ultimately preventing acetylcholine's access to the receptor. This prevention inhibits neurochemical signal from being transmitted from one neuron to the next, which attenuates the parasympathetic response. These agents have a high affinity but no intrinsic property, making them a static block that are simply there to occupy the receptor binding site. This inhibition can be reversed with more acetylcholine molecules present in the synapse or administration of acetylcholine agonists. Because muscarinic receptors are widely distributed throughout the body, they come with diffuse physiologic effects as well as side effects. The side effects observed with antimuscarinics are a direct result of their inhibition and can be viewed as the complete opposite effects than those seen with the parasympathetic response. In the eyes, there's pupillary dilation and lack of accommodation of the pupil, which can lead to light sensitivity and blurry vision. The positive chronotopy that occurs in the heart increases the heart rate, leading to tachycardia. In the lungs, dilation of the bronchial smooth muscle and decreased respiratory tract secretion leads to dry mouth. In the GI tract, there is a decrease in contraction and motility, which overall increases the rate at which gastric emptying occurs. In the bladder, there's relaxation of the detrusor muscle and an increase in urinary sphincter tone, which decreases eliminary function. In the glands, there's a decrease in sweat production, which enables someone to properly regulate their body temperature, and also a decrease in lacrimation, which dries out the eyes. In the blood vessels, there can be seen, there's a block in the vasodilation, which you may see a bump in the patient's blood pressure. Antimuscarinics are contraindicated in patients in which administration may actually worsen clinical symptoms or conditions altogether. These agents are contraindicated in glaucoma patients as the resultant pupillary dilation that occurs changes the drainage angle within the eye, leading to narrow angle glaucoma and risking loss of optic nerve function. They're also not indicated for patients with poor cardiac function, as the resultant tachycardia leads to increased myocardial workload, oxygen consumption and demand, and an overall worsening of myocardial ischemia. They're not indicated for any patients who are unable to clear their secretions and maintain their own patent airway, such as stroke patients and possibly patients with cystic fibrosis, as administration dries out airway secretions and may lead to mucus plugging and airway compromise. These agents are not indicated for patients with obstructive and restrictive GI and GU disorders such as pyloric stenosis and benign prostatic hypertrophy, as the decrease in motility and contraction in these organs risks the development of severe bowel obstruction and UTIs. In the pediatric patients who have higher metabolic rates, combined with the decrease in sweat production produced by antimuscarinics, this can overall lead to pyrexia and overall inability to manage body temperature and overheating. In the elderly, due to the likelihood of polypharmacy and physical and physiologic changes that occur as we age, such as a decrease in total body water and lean body mass, which increases the distribution of drug, and also the decreased liver and renal function, which can alter the way the body metabolizes and eliminates the drug, just overall increases the risk of drug-to-drug interactions and side effects. Antimuscarinics may decrease or even potentiate the effects of other drugs, such as antihistamines, tricyclic antidepressants, phenothiazines, monoamine oxidase inhibitors, and the likes. Some antimuscarinic agents, when given in higher doses, can actually act and produce a partial block on nicotinic acetylcholine receptors, and as such may exacerbate symptoms in neuromuscular disorders such as myasthenia gravis. Antimuscarinics in today's modern medicine is used to treat and manage a variety of clinical conditions and symptoms. A few of them are listed here on this slide. Scopolamine is used to treat motion sickness and used as an anti-sialagogue. Benztropine is used to treat and manage symptoms of Parkinson's disease. Homatropine and tropicamide are agents that are used as pupillary dilators for eye exams. Ipratropium, used via nebulizer, is used to manage and treat symptoms of asthma and COPD due to its bronchodilating effects. Pyrenzapine is a drug that is used to manage peptic ulcers. It inhibits gastric secretion and promotes healing of duodenal ulcers. Hyoscine is a drug that helps with GI hypermotility and is usually used to treat irritable bowel syndrome. And oxybutynine is used to treat an overactive bladder. Anesthesia implications for antimuscarinics are used in various phases of the perioperative period. For instance, preoperatively, glycopyrrolate can be used as an anti-sialagogue to manage secretions. This can facilitate oral surgery, manage secretions of a trach patient, and facilitate awake tracheal intubations. This agent can also be used to counteract the effects of increased secretions produced by ketamine. Another agent would be scopolamine, which is used as a prophylaxis for post-op nausea and vomiting. It's a little patch that goes right behind your ear and also is used to treat motion sickness. Intraoperatively, antimuscarinics are used to prevent or blunt the bradycardic response that occurs as a result of reflex activity, which can be induced by induction and intubation. Bradycardia induced by stimulation of the vagus nerve, which can come with surgical manipulation. And bradycardia induced by administration of anticholinesterase drugs that are used to reverse skeletal muscle paralysis. The bronchodilating effects that come with antimuscarinics can be used to treat bronchoconstriction in patients with reactive airways, such as ipratropium bromide. A specific drug in the antimuscarinic class, and one that is used quite a bit in anesthesia practice, is glycopyrrolate. Glycopyrrolate is available in a variety of formulas for administration and can be administered by mouth, intramuscularly, intravenously, and subcutaneously. It is also known by another generic name such as glycopyrronium bromide and its trade names as Robinal, Robinal Forte, Cuvposa, and Glycate. Like the other antimuscarinics in its class, glycopyrrolate competitively antagonizes the effects of acetylcholine at muscarinic acetylcholine receptors, which are located at end organ effector sites like the eyes, heart, lungs, GI tract, bladder, and glands. This antagonism prevents acetylcholine from stimulating these receptors and initiating a parasympathetic response. Glycopyrrolate has a high affinity for muscarinic receptors but possesses no intrinsic activity, making it a static block that can be easily reversed with a higher presence of acetylcholine molecules or administration of cholinergic agonists. Glycopyrrolate is a nonspecific antimuscarinic agent and thus has a wide range of actions. Glycopyrrolate has similar side effects as mentioned earlier, this being dry eyes, tachycardia, decrease in secretions and sweat production, as well as a decrease in GI and GU motility. The exceptions that come are the result of glycopyrrolate's structure-activity relationship. Unlike some other antimuscarinics, glycopyrrolate has a quaternary ammonium group, which makes it an ionized compound that is highly polar and water-soluble, which makes it less likely to cross lipid membranes such as the blood-brain barrier, the GI tract, and placenta. The structure also makes it more potent than other antimuscarinics and at higher doses increases blocking properties within ganglionic sites. Glycopyrrolate also produces tachycardia, but this is less than what's observed with other antimuscarinic drugs such as atropine. This agent is also the antimuscarinic drug of choice when co-administered with a cholinesterase inhibitor such as neostigmine to reverse skeletal muscle paralysis that's induced with non-depolarizing neuromuscular blocking drugs. Glycopyrrolate is contraindicated in patients in which administration may actually worsen clinical symptoms or condition altogether. They are contraindicated in glaucoma as the resultant pupillary dilation that occurs can change the drainage angle within the eye, leading to narrow angle glaucoma and risking loss of the optic nerve function, leading to blindness. They're also not indicated for patients with poor cardiac function as the resultant tachycardia increases myocardial workload, oxygen consumption and demand, and overall worsens myocardial ischemia. It just may not be tolerated in patients with poor cardiac reserve. They're also not indicated for patients who are unable to clear secretions on their own, such as stroke patients, and may also not be good for patients with cystic fibrosis as administration dries out secretions and may lead to mucus plugging and airway compromise. These agents are not good for obstructive and restrictive GI and GU disorders such as pyloric stenosis and benign prostatic hypertrophy, as the decrease in motility and contraction in these organs can risk development of severe bowel obstruction and UTIs. In the pediatric patient, due to the decrease in sweat production produced by glycopyrrolate and the higher metabolic rates of children, these agents can lead to pyrexia and overheating. In the elderly, due to the likelihood of polypharmacy and the physical and physiologic changes that occur as we age, such as the decrease in total body water and lean body mass, which may increase distribution of the drug, and the decrease in liver and renal function, which may alter the way the body metabolizes and eliminates the drug, can increase the risk of drug-to-drug interactions and overall side effects. Antimuscarinics may decrease and even potentiate the effects of other drugs that are concomitantly used. Some examples include antihistamines, tricyclic antidepressants, phenothiazines, monoamine oxidase inhibitors, and the likes. Some antimuscarinic agents, when given, such as glycopyrrolate, when given in higher doses, can actually produce a partial block on nicotinic acetylcholine receptors, and such are not indicated for patients with myasthenia gravis, as they can exacerbate symptoms in this disease and actually lead to myasthenia crisis. In anesthesia practice, glycopyrrolate has a number of uses throughout the various phases of perioperative period. For instance, preoperatively, it can be used for its anti-sialagogue properties to help manage airway secretions for procedures to take place, such as oral surgery and awake tracheal intubations. It can also be used to counteract drug-induced increases in secretions, such as what is produced with the administration of ketamine. Intraoperatively, it can be used to prevent or blunt the bradycardic response that occurs as a result of laryngoscopy and intubation and surgical maneuvers. After surgery is complete, glyco can be used to reverse neuromuscular blockade that is induced by non-depolarizing neuromuscular blocking drugs. These drugs cause bradycardia, hypotension, bronchoconstriction, excessive secretions, and nausea. And the administration of glycopyrrolate attenuates all those responses. Glycopyrrolate is paired with neostigmine to reverse the neuromuscular block. The following slide is the recommended dosing for glycopyrrolate in the adult and pediatric patient population. In the adults, for use as an anesthesia adjunct, preoperatively as an anti-sialagogue, the recommended dose is 4 mics per kg IM times 1, 30 to 60 minutes before anesthesia. Intraoperatively, to reduce the bradycardic response, it's 0.1 milligrams IV every 2 to 3 minutes PRN. To reverse neuromuscular blockade, the recommended dose is 0.2 milligrams IV for every 1 milligram of neostigmine. In the pediatric patient population, anesthesia adjunct uses include preoperative use in the 1 to 23-month-old as an anti-sialagogue is 4 to 9 mics per kg IM. Should be times 1, 30 to 60 minutes before anesthesia. Preoperatively, for patients greater than 2 years old, the recommended dose is 4 mics per kg IM times 1, 30 to 60 minutes before anesthesia. Intraoperative use, which is going to be to prevent bradycardia in patients greater than 1 month old, is 4 mics per kg IV every 2 to 3 minutes PRN with a max dose of 0.1 milligrams per dose. To reverse neuromuscular blockade, it's 0.2 milligrams IV for every 1 milligram of neostigmine. Special populations to consider when administering glycopyrrolate include those with renal impairment, the elderly, and pediatric patients. Glycopyrrolate undergoes very little metabolism and is primarily excreted unchanged in feces via biliary excretion and in the urine. It's said that up to 80% is excreted in urine. So patients that have a GFR of less than 30 milliliters per minute is going to lead to a decreased plasma clearance of the drug and decreased excretion in drug and overall increase in the duration of action of glycopyrrolate. So a decreased dose is recommended in these patients. In the elderly patient population, due to the likelihood of increased polypharmacy and age-related changes that occur in the body, these patients are more at risk for detrimental drug-to-drug interactions, and thus a decreased dose should be also considered. In the pediatric patients, specifically neonates and older infants, glycopyrrolate should be used cautiously due to the increased metabolic rates in this patient population and decreased sweat production that occurs with glyco, which can cause overheating. And that's the end of my presentation, so thank you very much. And here's a cute picture of my dog.